first CCR after the COVID pandemic. This department was established in the year 2017 under the able guidance of our visionary Dr. M.N. Swankar sir. And after the inception of this emergency medicine program in 2020, we never looked behind. Just before starting with CCR, I'll just give a overview of my department in a brief few slides. The inception was in the year 2022. We were given the permission to start 2 seats in the emergency medicine, and at present I have 7 residents including 1 SR. Our nursing staff is around 30, and we have 2 faculties in the department. The strengths and resources, the institute has provided us with the best possible facilities to us. We have all the facilities in the emergency department, like our own point of care faculty, point of care ultrasonography, video laryngoscopes, and central venous access catheters, ventilators with the difficult airway trolley in the emergency area only, multiple defibrillators with transcutaneous pacing, round-the-clock point of care labs over there like ABG, cardiac panel, and our central lab is also totally functional for 24 hours. We have an emergency OT facility also to have that surgical emergencies to be dealt there only. Then these are the facilities. This is the resuscitation area with ventilator and sonography machine. This is the emergency OT. Our faculty is also enrolled with our certain training programs which are very much necessary for the emergency medicine people to have, like trauma life supports, basic cardiac life support, and advanced cardiac life support, and certain workshops like ECMO and USG. We are day-to-day teaching the UG and PG residents and training the staff also. Certain highlights of the year 2022. Yeah, we have CT. No, sir, not the picture, yes, but we have X-ray and CT scan. Yes, in that emergency area only. All the things functional 24/7. CT scanner. So this is the footfall of the patients. Last year we had around 30,000 patients in ED presenting to us, out of which 9,000 patients were admitted into the hospital, and around 16 to 17,000 patients were treated and discharged from the emergency medicine department with the help of other specialties and super specialties. And the special focus is on the patients who are coming with the cardiac arrest, out of hospital cardiac arrest and in hospital cardiac arrest. So around 54 patients in the last 6 months came to an ED, and out of them 20 patients we were able to achieve the spontaneous circulation, and out of this 3 to 4 of them were discharged from the hospital without any neurological deficit. And it is at par with the international standards, which say that there are around 7 to 8% patients who can be discharged, who are being discharged from the hospital without any neurological deficit after a CPR. We had a patient who underwent around 40 minutes of CPR with around 10 to 15 of DC shocks, and that patient was discharged on 5th day from the hospital after his angio from the cardiology department walking. So there was no neurological deficit despite the fact that he was given CPR for 45 minutes and 15 shocks also. So that was a big achievement for us. And we are also thrombolizing the patients in ED with under the able guidance of our neurology team also. And around 15 patients in last 1 year have been thrombolized in the emergency department. And we are performing all the procedural skills which are required for the emergency medicine department, like intubations, on an average 1 to 2 intubations per day. Around 35 per month have been performed, and placing the central line catheters in the ED, performing the intercostal drainage or placing the ICD tubes, then the different nerve blocks and the foreign body removal are also being done in the emergency department. Our vision is to make the ED pain-free and to have a pre-hospital care, which is very much important, a part of an emergency medicine department to have. With this, I'll just give this mic to my resident, 30 PG resident, to proceed with the case, today's case. Yeah, trauma is also included, sir. But trauma is around 2,500 to 3,000 patients per year. We are seeing the trauma, and on an average, 300 patients per month. So around 25% of the trauma ED patients are trauma patients, which we are handling every day.
Good morning, esteemed faculty, all my seniors, all my colleagues, all my friends. My name is Dr. Nakul Sharma, and I am a third-year resident in the Department of Emergency Medicine. So let us begin with the CCR for today. The heading for the CCR is a case of lower limb weakness in a middle-aged female, and we are collaborating with the departments of neurology, radiodiagnosis, neurosurgery, and neuroanesthesia. So let us begin. Let me introduce the case to you first. We had a 34-year-old female who had a lower segment cesarean section 4 days back, who presented to the emergency department of Mahatma Gandhi with the complaints of fever which occurred 2 days back and occurred for 1 day, followed by severe pain in the gluteal region which radiated to both the lower limbs till the feet and was followed by weakness in both the lower limbs, and the passage of stools in her clothes on the morning of the presenting day. Elaborating on the history, the fever occurred 2 days back and lasted for 1 day. We had no records available of the fever, but it was not associated with chills or rigors and was relieved on taking antibiotics. Then she developed severe pain in her bilateral gluteal region, which radiated to both the lower limbs till the feet. It was sudden in onset, diffuse in character, and worsened at night. And there were no relieving factors to the pain. It occurred a day after the occurrence of the febrile episode. This was followed by pain in the lower, the pain was followed by numbness and then weakness. The numbness was initially in the left lower limb and then it occurred in the right lower limb. This was followed by weakness, and the weakness was progressive in nature. It was so bad that on the day that the weakness started, by evening that day, 10 p.m., she was completely unable to move her lower limbs. And this was followed by the passage of stools in her clothes on the morning of the presenting day, and as she had no control over her bowel movements. In the negative history, she had no headache, vomiting, chest pain, cough, shortness of breath, or history of abnormal behavior, and there was no history of trauma.
What about bladder?
Sir, the patient had been catheterized following her LSCS, so we could not assess for bladder dysfunction. In the Sir, the cesarean was under spinal. We mentioned that in the next slide. So the LSCS was performed 4 days prior outside of Mahatma Gandhi Hospital under spinal anesthesia. She had been recently diagnosed as having hypothyroidism a month back and was on tablet levothyroxine regularly. She had no history of diabetes mellitus, hypertension, ischemic heart disease, or tuberculosis. In the obstetric history, she was para 1, living 1, and abortion 0, and had a 3-day-old male child. The lower segment cesarean section was done in view of query failure of induction and query oligohydramnios. Although we didn't have records, this is what was given to us in the verbal history by the patient herself. And she had been going for regular antenatal visits, and there she was told that she did not have any abnormalities, except for the fact that she was diagnosed with hypothyroidism a month back in the 3rd trimester. So let us review so far the case at hand based on history. We have a 34-year-old female recently diagnosed with hypothyroidism, post lower segment cesarean section 4 days back. She had fever 2 days back, bilateral lower limb pain followed by weakness, and bowel incontinence. She had no other chronic illnesses and had an almost uneventful antenatal period. Based on this, I would like to ask all of you, what would your differential diagnosis be for this patient?
Acute onset, paraplegia or paraplegia
with bowel volume.
and possible volume.
So it might be because of trauma to the either to the spinal nerve rootlets or the spinal cord itself.
Any other possibilities?
Compression neuropathy might be because of the
Within hours. morning to evening.
Mostly spinal there might be some
What is more common than that? What happens like this within a few hours? A vascular event.
vascular events leading to hematomalformation leading to
Acute
compression.
demyelination. These possibilities have to be kept. Anything else?
All right, so we come on to our differential diagnosis. This could either be a traumatic event or a non-traumatic event. If it is a traumatic event, it could either be due to vertebral fractures with cord compression. In the non-traumatic events, it could be a conus medullaris syndrome or a cauda equina syndrome. Infectious diseases could be a spinal epidural abscess or a viral myositis. These are all differentials of paraparesis that I'm telling. Inflammatory diseases could be there, which could include Guillain-Barré syndrome or a transverse myelitis. Neoplastic diseases, including primary spinal cord neoplasms or metastasis. Metabolic diseases, including hypo or hyperkalemic periodic paralysis. And vascular conditions, which could be an anterior cord syndrome. The cauda or conus could be due to either PIVD, a spinal hematoma, vertebral osteomyelitis, or a discitis. So these are.
Are you discussing the DD for your case or the paraplegia in general?
Sir, specifically for our case, there could be more differentials for paraplesias in general, but
Do you have a neoplastic cause producing a paraplegia within a few hours?
sir, not generally.
With secondary change, suppose there is a hemorrhage in the tumor.
Yes, sir.
Then it can.
Then it can be, but not generally, so which is why we've kept it a little bit down in the differential. These are all in terms of the probability of those occurring, mostly. Moving on to the general physical, the examination. Let's start with the general physical examination. The patient was anxious, lying in a supine position. She was pale. There was otherwise no edema, clubbing. The edema was present. It was bilateral and pitting in nature. There was no icterus, clubbing, cyanosis, or lymphadenopathy. Vitally, she had a pulse rate of 84 per minute, regular and with good volume. The blood pressure taken in the supine position was 124 by 80 mm of Hg. The respiratory rate was 24 cycles a minute, and the saturation at room air was 94%. She was afebrile, and moving on to the systemic examination, cardiovascular examination was unremarkable, no positive findings. Respiratory system again was unremarkable, bilateral air entry, normal vesicular sounds, no added sounds. The abdominal exam revealed a dressing present over the lower abdomen on the suture site. Sir, the lub-dub sounds that we hear. The abdomen was soft, it was non-tender, there was no guarding or rigidity. The uterus was palpable below the umbilicus at around 16 weeks level, and there was no other organomegaly. Coming on to neurological examination. She was right-handed and was conscious and oriented to time, place and person and following commands. The cranial nerve examination again was unremarkable, no changes. In the motor examination, bilateral upper limbs, the power was normal, it was 5 by 5. In the lower limbs, it was reduced to 1 by 5. The bulk in all muscles was normal, and there was reduced tone in the bilateral lower limbs. The deep tendon reflexes revealed normal reflexes, as you can see in the figure. Normal reflexes 2+ grading in both the lower, upper limbs, and absent deep tendon reflexes in the lower limbs, 0 grading. Bilateral plantars were mute, but the abdominal reflexes were preserved. Coming on to the sensory examination, fine touch, sense of vibration were both completely absent below the inguinal ligament, as you can see in the figure, while decreased sensations of crude touch, pain and temperature were also present below the same region. Above the inguinal ligament, the sensory examination was normal. The passive straight leg raise test was also negative. There were no signs of any meningeal irritation. no neck stiffness, no Kernick sign, no Brudzinski sign, and the cerebellar examination was normal. Of course, we couldn't perform it in the lower limbs, but in the upper limbs it was normal. We also did a distal rectal examination which revealed a decreased tone of the anal sphincter. Since a Foley catheter was in situ after the caesarean section, we could not assess for bladder dysfunction. The spine revealed no deformity, erythema or bruising, and there was no paraspinal or midline spinal tenderness. So these are the investigations that we sent. The complete blood count revealed a normal white cell count. The hemoglobin was reduced, it was 9.1 grams per deciliter. Platelets were around 180 lakhs per mm. The RFTs were normal, the LFTs, which we'll come to, were also normal. The thyroid function test revealed an elevated TSH and a normal T4, T3. And the electrolytes were also normal, with the serum sodium being 145 and serum potassium being 3.58.
So I have a suggestion for you. Whenever somebody has a low hemoglobin,
Yes, sir.
the RBC indices should be mentioned. Because whether it's a microcytic anemia or a macrocytic anemia, that you can crudely assess.
Yes, sir.
If it is normal, then one will be good. But if it is abnormal, then you should.
Yes,
I
sir.
will be very keen that many MCV.
Yes, sir.
What is the normal level of sodium? Normal range of sodium?
Sir,
Potassium.
sir, potassium is 3.5 to 5. Some labs say it's around 5, some textbooks say it is 5.5. So around 3.5 to 5. Moving on, the liver function tests were also normal. The ESR was 12. The blood sugars were 165 milligrams per deciliter. The INR and APTT again both were normal, within range. The ECG showed a sinus rhythm with inverted T waves in leads V1 to V4, which was expected with her sex and age. And the chest X-ray again was normal. So, based on the history, examination and investigations, let us again summarize the patient. We have a 34-year-old female, post caesarean section, had fever for 1 day, 2 days back, weakness in the bilateral lower limbs, and bowel incontinence. On examination, had a paraparesis of the lower motor neuron variety, with the absent sensations below the inguinal region, had bowel involvement present, and had a normal CBC except for reduced hemoglobin, normal metabolic panel, and normal bleeding profile.
So why are you concluding that this is a lower motor neuron paralysis? It could be a UMN with shock state, flaccid shock.
Sir, could be a UMN with shock, but with the history of weakness being for around 2 days, I would say the shock would have improved by now. Spinal shock.
Who takes from the morning to evening?
Sir, weakness was 1 day back, so she presented to us in the evening. Progressed over 2 days.
One thing I would like to know is the local back examination.
Yes, sir.
Any evidence suggest spinal
No, sir. Spinal exam was normal. No findings.
So I would call it acute onset paraparesis.
Yes, sir.
I would say element at this time. Element possible UMN with the
Spine.
shock, that is also possible. And you're saying that the abdominal reflexes were present.
Yes, sir.
So I would keep that possibility in mind. I haven't done neurology for 4.5 years now, but still. अब न्यूरोलॉजिकल डायग्नोसिस बताइए इसका मेडिसिन वाले या पहले मेडिसिन वाले उसके बाद फिर
Next slide.
what is the full neurological diagnosis in this patient?
It will come later on, sir. We will reject the project.
Let's ask the students. Anybody volunteer?
So let us come back to our original differential diagnosis that we created based on the history. This was our original differential. based on the findings that I have said in the examination and the investigations, what could be the possible differentials that we could rule out from this original list?
Have we done any radiological examination of radiological investigation?
Not so far, sir. We have, but not right now. We did it a little later. This is based just on clinical examination and the lab findings that we had. Okay, so the highlighted differentials are what we kept based on the examination and investigations. It could still be a conus or a quadra syndrome. It could still be a spinal epidural abscess. Unlikely to be viral myositis, unlikely to be a GBS. Could still be transverse myelitis. We've ruled out trauma since there was no history of trauma. The examination was not suggestive of any trauma.
The history of trauma is there. She had a lumbar puncture.
Sir, in terms of spinal pathologies, trauma by convention includes a traumatic event such as an accident or a fall or assault.
Was the patient gave trial for normal labor before cesarean?
No, sir. She was not given a trial. What the history that we were given were that she went to the hospital. They said that your baby is not coming out. There is not enough fluid in your amniotic sac, which is what the verbal history was given. So they just went ahead with the cesarean.
The first one was a normal.
This was a first delivery, sir. First delivery. Yes, sir. So again, we realized that.
How did you rule out vascular event?
Sorry, was?
Epidural abscess.
Vascular event should be kept as a differential diagnosis, still alive, and not anterior cord syndrome, but vascular event at the site of puncture to the spinal anesthesia.
But that is still included. We have spinal hematomas as a
Not just
difference.
hematoma, but some vascular injury.
Some other vascular injury also.
Leading to ischemia at the
The anterior cord syndrome, sir, because the pattern of the disease is not consistent with an anterior cord syndrome, you would generally have involvement of pain and temperature sensation, but not the dorsal tract sensations in the anterior cord syndrome. And this patient had a complete involvement.
So you are calling it as a lower motor neuron paraparesis, and you are having transverse myelitis as your DD, so you might as well have that also as your DD.
The anterior cord syndrome. So transverse myelitis is again slightly less of a possibility since we have no human findings here.
You have highlighted?
I have, sir, but again in terms of our order of differential, it was more likely to be a conus cauda or a spinal epidural abscess with the possibility, a slightly lesser possibility of transverse myelitis. So based on the above findings, we realized that a spinal pathology was likely to be the culprit in this patient, and so we performed a neurology reference to discuss further course of action and further evaluation. So handing over to my neurology colleague, Madhu Vas.
A very good morning to respected teachers and my dear colleague. I am Dr. Madhugandha from the Department of Neurology. So today we are discussing this case of 34-year-old female who was post LSTS day 4, which presented to us with history of paraparesis for 1 day. As discussed by Dr. Nakul, we have established up till now that this patient mostly had a non-traumatic spinal cord lesion. So for any spinal cord lesion, the most important part is localization for further workup and management. So let's first see the normal anatomy of the spine. This diagram here shows the sagittal and the coronal images of the spine, in which we can see 31 pairs of spinal nerves in cervical, thoracic, lumbar, sacral and coccygeal. The T1 to T12 to middle part of the L2 forms the conus medullaris, this one, and the nerve rootlets below are called as the chorda equina. Now let's go through the different causes of paraparesis. In our patient of non-traumatic paraparesis, the causes could be compressive or non-compressive. The compressive causes could be intramedullary in the form of lumbar syringomyelia and matomyelia. Extramedullary causes could be intradural, which could be a spinal meningioma or hypertrophic pachymeningitis. Extradural causes could be port spine, prolapse IVD, epidural abscess or hemorrhage, a fracture dislocation of the vertebra. In non-compressive lesion, the causes could be a motor neuron disease like hereditary spastic paraparesis, which is unlikely in our patient because the patient had mainly element type of paraparesis and was not progressive. The patient, it could be multiple sclerosis, acute transverse myelitis, subacute combined degeneration of the cord, Guillain-Barré syndrome, especially the paraparetic variant, myositis or myopathy, anterior horn cell diseases like poliomyelitis. Clinical differentiation of a compressive or a non-compressive lesion. So for this, our patient specifically had a sensory level and she had radicular pain, which goes more in the favor of a compressive lesion. Further differentiation of the lesion for the type, whether it is extramedullary or intramedullary, as the patient had mainly root pain, which is common with extramedullary, and there was involvement of the sacral segment. It goes in the favor of extramedullary. Because the patient already had early bowel bladder involvement, which is mainly seen in intramedullary, but if a severe extramedullary lesion is present, it can be seen with extramedullary also. Then the patient, for the localization between extradural and intradural, because the patient had involvement of root pain, which goes in the favor of intradural, then there was rapid onset, which again is a favorable point for intradural, and there was no vertebral tenderness. So this goes in the favor of intradural lesion. So this diagrammatic representation is for differentiating between an extramedullary, extradural or intradural versus an intramedullary lesion. So in this you can see the lesion is outside the dura and outside the substance of the spinal cord. So this is an extradural lesion. This shows a lesion which is present inside the dura but outside the substance of the spinal cord. So this is an intradural lesion. And in this we can see that the lesion is inside the substance of the spinal cord. So this is an intramedullary lesion. The clinical summary of our patient, she had sudden onset, symmetrical, element type of paraparesis with radicular pain and bowel bladder involvement. So for this, can anyone tell me what could be the localization? To differentiate further, if the patient is having involvement of conus and chorda, we'd like to go through this table. As the patient had sudden and bilateral onset, it goes in the favor of conus medullaris. The patient had early involvement of bowel and bladder, which again is in the favor of conus medullaris. The patient had element type of weakness, which favors chorda equina. CSD4 presented with 2 days history of acute onset paraparesis, which was symmetrical in onset. She had severe backache, which was radiating to both lower limb, which is suggestive of a radicular pain. There was presence of bowel bladder involvement. And on examination, she had element type of paraparesis, absent anal reflex, so sensory loss of all modalities with sensory level at T12 to L1, and preserved abdominal reflex. So, our diagnosis goes for Korda-Conner syndrome with localization at or below T12 to L1, and most probably an extramedullary intradural compressive lesion. The choice of investigation as Korda-Conner syndrome, in this there is overlap of chorda and conus as we have seen here. The patient may have involvement of lesions in multiple segments, and this is a medical emergency because of the reversibility of such cases. So urgent neuroimaging is crucial in this patient, and so we decided to get an MRI dorsolumbar spine with contrast for this patient. I would like to call Dr. Gandhi for further discussing about the radiological part of this. Thank you.
What is the neurological level, and is there any partial preservation in this case?
So because the patient had, so I would like to go to Dr. Nakul's side, if you'll allow me. So we can see here that the patient basically had reduced tone in both lower limb. So which shows that the patient is most probably having a lesion in the dorsal region or in the lumbar region, because paraparesis most, if a patient presenting to us with paraparesis, we suspect a lesion below the cervical, obviously. Then the patient had preservation of abdominal reflexes. So this shows that the lesion is most probably below T12 level. Then on sensory examination, there was loss of reflexes in both lower limb. And if we see on sensory examination, you can see the level of lesion almost at L1. It was at the level of inguinal ligament. But there was no zone of hyperesthesia present in this patient.
But there is no key muscle to test the L1. So how can you say that it's an L1 motor level?
So that's why I have suggested surgeons, it could be below T12 to L1. I am not pointing out that it is exactly at that level, just because the patient had preserved abdominal reflexes, but when we tested for her hip movements, the movement was not there and she was not even able to move her leg. The power at hip was 1/5. So we suspected that the lesion could be below T12, but I am not commenting that it was exactly at that level. Thank you.
And there is an accent of dynasty difference in weight, and it shows that the lesion is L1 or below L2.
And I think one more extremely important thing when you do the examination is whether it is a compressive or not. What is the compressive lesion?
So I have shown in my slide that the patient is most probably was suffering from a compressive lesion. Just because if we see the differentiation between a compressive and a non-compressive lesion, the root pain goes more in the favor of a compressive lesion as well as a sensory level, which is not seen mostly in non-compressive lesion.
Then we can see a heterogeneous, this is a hyper-intense lesion, this is a T1 weighted image. A hyper-intense lesion is seen inside, which is not displacing the dura. Further, we can also see that the epidural fat, which is a hyper-intense line here and here, is well preserved, anteriorly as well as posteriorly. We can also see that the lesion is causing compression over the nerve roots here as well as here. The black dots here are the nerve roots. So these are the pre and the post contrast images, sagittal sections, and we can see that in the post contrast image there is no contrast enhancement taken up by the lesion. Again, the epidural fat, that is anterior and posterior, is well preserved. The hypointense dura is not displaced. So this, the second image is actually a normal image of a spine, that is an axial section, and here we can see that a normal thecal sac inside there is a CSF filled thecal sac and the nerve roots. This is a normal appearance. Whereas in our patient we can see that it is almost obliterated. So there are different appearances of blood on MRI, and according to the stage, blood would appear different on T1 and T2 sequences. So in our case, on T1 it was appearing hyper-intense predominantly, and on T2 it was hypo-intense predominantly. So this is the early subacute lesion, early subacute blood. So the differential diagnosis could be epidural, subdural or a subarachnoid hematoma, a subdural abscess, subdural hygroma, and it could also be neoplasms like meningiomas and MEDS. So first of all, an epidural hematoma would present with thecal sac displacement and epidural fat which may not be visible. So in this first image is a sagittal section in which we can see posteriorly there is this lesion that is compressing the cord and the canal. And on axial section we can see that the dura is displaced from the posterior part, and this lesion is causing compression over the spinal cord. Also, the epidural fat is not clearly visible as was visible in our case. The next is the subarachnoid hematoma. In subarachnoid hematoma, there will be layering of blood in the CSF space. That is a sedimentation sign in the dependent parts. That is the lumbar system. So in this first image, we can see that as the patient was lying supine, we can see a sedimentation sign. That is a fluid level. Also, the fluid level, that is a sedimentation sign. There could also be a localized or organized hematoma that may be seen in the non-dependent parts, but it is a rare entity, and in that case, it will be difficult to differentiate from a subdural hematoma. Other differentials could be subdural abscess, but they are usually associated with clinical features like fever with chills. They also show peripheral rim enhancement on post-contrast sequences, and they would not be T1 hyperintense and unless there is presence of blood, and they're not hypointense on T2. Also, they're rare entities. Just over 100 cases are known to us in literature. Subdural hygromas. So hygroma is it's a CSF collection trapped in the subdural space. They could be history of trauma or it could be iatrogenic, and they will appear normal like CSF. They will appear like the normal CSF on all the sequences of MRI. Again, they are rare entities, and the prevalence is still not known. Neoplasms like meningioma and METs would present with intense homogeneous enhancement on post-contrast sequences, which was not seen in our case. So our final radiological diagnosis is the early subacute subdural hematoma. The points in favor is that epidural fatty tissue is preserved, both anterior and posterior. There is no inward displacement of hypointense dura mater. That suggests that the lesion is inside the dura, it is not outside. In subdural hematomas, they follow a rule that there is actually, this is the central part of the spinal cord, and there are two tentacular ligaments that attach the spinal cord, and posteriorly we have a dorsal septum. So in the subdural space, any collection, it assumes the form of this inverted Mercedes-Benz sign. And in our case, we can see here that in this image, we can see that the anterior most compartment is involved and the posterior lateral compartments are not involved. So the final diagnosis is early subacute subdural hematoma.
Very good morning to all. I shall be discussing the neurosurgical part. As the diagnosis was already made, neurosurgical intervention was required. The patient was explained, and after taking a due consent, the plan was for decompressive laminectomy. Patient underwent a laminectomy from the L1 level to the L5 level with the repair of the dura and the evacuation of the hematoma. In the post-op period was uneventful. The patient was kept with us in ward for 3 days and was discharged following an improving lower limb PAR. At the time of operative intervention, the PAR was 1/5, and post-operatively at the time of discharge, the power was 2/5, the bilateral lower limbs. The Foley's catheter was kept in C2. As in this video, you can see. As you can see, after the laminectomy has been performed, hinge sutures have been taken and dura has been put on both the sides. The clot is being evacuated in a piecemeal fashion in order to make sure that the spinal cord is not injured at all. From the L1 level to the L5 level, the clot was evacuated in a piecemeal fashion. Post the evacuation, watertight closure of the dura is done, and post-operatively the patient was, as mentioned, kept with us for 3 days.
Be cautious in that there is no spinal cord involved.
So, where was the hematoma found? In epidural or in subdural?
So subdural space. The hematoma was found in the subdural space.
So most of the time, if it has happened due to the spinal puncture, then there would be the epidural, higher chances of epidural hematoma.
So, but in our case, it was found in the subdural space.
But it was in subdural space.
This more anterior.
And more anterior.
More anterior.
Even we don't know history of multiple puncture could be there for spinal.
Could be, but there are chances of engorged vein in epidural space, not in subdural area.
Diagnostic lumbar puncture we usually perform in neurology, and for last 10 years I have not seen a single case. Even they have not referred from outside. But what was the reason? In lumbar puncture that was performed for surgery, especially cesarean or something else, they are not going to develop hematoma. But diagnostic lumbar puncture is quite common. We are doing 4 or 5 cases per day.
So I think that is one question which I want to ask. Was the coagulation workup done in this patient?
Yes, coagulation, engorged blood vessels.
No bleeding diastasis.
Patient was not on
Let us be more systematic.
Good morning everyone. Now I will discuss the anesthetic management. As discussed, this patient was posted with us for the L1 to L5 laminectomy and evacuation of the subdural hematoma. We decided to take this case under general anesthesia. So on pre-anesthetic evaluation, we found significant that she had taken a full solid meal just 2 hours back. So our concerns, they become in respect to this. On pre-anesthetic evaluation, we also found that investigation, as discussed earlier, that she was mildly anemic with a hemoglobin of 9.1. Her thyroid stimulating hormone level were in a higher range of 12.25. So our concerns become that she is a post-cesarean female. So these patients, they are known to have an increased sensitivity to sedative agents and as well as the neuromuscular blocking drugs. She is anemic. She has a hypothyroidism, so they have a risk of delayed recovery. The surgery was to be done in prone positioning. So prone positioning, it imposes various challenges for us. There is a hemodynamic compromise. There are increased airway pressures. There may be pressure-related injuries and also airway edema. Lastly, the patient is full stomach as she has taken a full meal 2 hours back. So there are higher chances of aspiration. So in our management in the preoperative area, we gave her anti-aspiration prophylaxis in the form of ranitidine and metoclopramide at least 30 minutes prior to the surgery. We took a high-risk consent in view of aspiration. And as per the American Society of Anesthesiologists guidelines, we applied the standard monitorings and also the deep vein thrombosis pump prophylaxis were applied. So during the induction of anesthesia, we chose a rapid sequence induction technique in which we firstly pre-oxygenated the patient for at least 5 minutes with 100% oxygen. We used rocuronium as a muscle relaxant, which has a rapid onset of action and it provides us the intubation facilities within 60 to 90 seconds. And in this technique, as shown in the picture, we can see that in this technique we have one assistant who stands on the right side of the patient. He applies cricoid pressure on the throat of the patient, starting from the time of starting the induction till when we have in place the tube and the tube is confirmed with the capnography, then only we release the pressure. Then in this way, after the intubation is done, we placed a Ryle's tube in situ and aspirated the contents, suctioned the contents of the stomach. The surgery was done in the prone position. So in this case, there are 2 kinds of the bolsters that can be used for the prone positioning. We prefer the use of a Wilson frame which has 2 parallel rods so that there is no pressure on the scar. If we use the bolster that can be seen in the figure 2, there can be pressure on the cesarean section scar and there can be descents. So to avoid that, we used a Wilson frame. The surgery was uneventful. We maintained the standard anesthesia as we do, and the extubation was done in fully awake state after the return of protective airway reflexes. Thank you. Now I hand over the dice to Dr. Nakul for further discussion. Thank you.
Okay, so we've come to the end of our case. So it was most likely an iatrogenic subdural hematoma during the LSCS that occurred, presented to us with a paraparetic patient with a combined conus cauda syndrome. It got evacuated as soon as we reached the diagnosis. This was all very early with team management, early references, early management, and it ended up, as we will tell you, in a positive outcome. So let us review the literature. Now, non-traumatic by convention, extramedullary intradural hematomas are extremely rare. Extremely rare. Why I am saying extremely rare is because let us look at the general complications of neuraxial anesthesia. The complications in this list at the top these are the common complications that occur. But spinal hematomas are in itself very rare. They occur in almost 1 case in 2 lakh spinal punctures, and out of those, most of them are epidural. 75% are epidural hematomas. Intradural hematomas are extremely uncommon. They only comprise 4.1% cases of what is a 1 in a 2 lakh case phenomenon. So this was an extremely rare case. What are some of the causes of extramedullary intradural hematomas? It could be iatrogenic, including medical procedures like spinal anesthesia and spinal puncture, use of anticoagulants, bleeding disorders, vascular lesions, or neoplasms. In our case, it was iatrogenic. So most spontaneous extramedullary intradural hematomas are associated with anticoagulation, mostly warfarin or LMWH. Our patient was not on any of those. There was only one case reported with apixaban in a ST elevation acute myocardial infarction, and the most common location being the thoracolumbar region. That is where most intradural hematomas are found. So just a little.
Short of time. Just to interrupt, it was intradural, but also it was subarachnoid. It was not intradural extraarachnoid. So the differential you said it was coming in 15% of the acute, not 4% of it.
But the subarachnoid part was only slight. It was mostly a subdural hematoma.
Because at the level of the typical set, there is no much difference between dura and arachnoid. So
Yes, sir.
the hematoma which was present was subarachnoid.
That is what I am coming at. This is the slide that will
So it
explain
was
that.
in that 15%, not 4%.
Okay, sir. So just a little brief pathophysiology of intradural hematomas. So there is no specific anatomic subdural space in the spine. The dural layer and the arachnoid layer are extremely closely attached. So there is no actual anatomical space there. Electron microscopic findings have revealed that the weakest part of the dura in the spine is the dural basal cell layer. So that is what happens during the hematoma formation, is that there is splitting of the dural basal cell layer in which the hematoma is formed, rather than between the arachnoid layer and the dural layer. So these hematomas are better called intradural rather than subdural. So this is just something that we wanted to point out. Now, how do spinal hematomas present generally to you? Subdural, intradural hematomas. These are the features that you commonly see, and the highlighted parts are the parts, clinical features that our patient had. So had radicular pain in thighs, feet, buttocks, worsened at night time, numbness, weakness, bowel bladder involvement, and history of spinal manipulation. So you can see that this was, in those terms, quite a common presentation for a subdural spinal hematoma. In terms of investigations, an MRI of the spine is the investigation of choice. If you don't have a MRI of the spine available, you could go ahead with a CT myography, but again, it is not the gold standard investigation. Treatment is urgent neurosurgical evacuation. The earlier you do an evacuation, the better for the patient. In patients who do not have neurological deficits, a conservative approach may be tried with very close follow-up, but again, only a handful of such cases have been reported. Outcomes improve based on the neurological status before the evacuation. The better the neurological status before evacuation, the better the outcome. The earlier the diagnosis, earlier the evacuation improves the outcome. So I'll call Dr. Suchita Vaya ma'am to discuss the key learning points from our case.
Can I just ask, is it published? Is this case
No,
published?
sir.
No, sir, not.
Please do that.
Yes, sir.
In the long-term follow-up.
Yeah, this patient is under follow-up of neurosurgery department. She is coming. We have shown that video. Pardon, sir?
We have a video.
Yes, sir. Video has been. So the key learning points for all the residents who are seeing the patient at the first hand, because it is always said that one who sees the patient decides the outcome of the patient. So you have to be very vigilant when you are seeing a patient of paraparesis, and be careful when you are seeing it after a spinal or epidural anesthesia, because it's a very rare entity as all of us have seen, and the timely diagnosis with early evacuation is very much important for the outcome. And the team-based approach with the neurosurgeons, neurologists and radiology department is very much important to come to the better outcome of the patients. Now, this is the video. PAR is improved to 4/5 now. She came on 3rd of November and she was operated on the 4th. Within 24 hours, less than 24 hours, she was operated in the. This is a recent video, 5 days back only.
Do we expect more improvement?
Yeah.
Sir, it will take time, 4 to 6 months, yes.
Dr. Saraswat has the importance of surgery.
Do we have a follow-up imaging to show that the hematoma is completely gone and there is no residual lesion in the spine? I mean, recovery may be some residual lesion that is not completely evacuated.
So basically, it was more
I mean, improvement is she should be back to pre-morbid fitness, which is not the case yet.
Sir, if bulk is not compressing the nerve, then yes, it is just the decompression which is required, not the whole hematoma to be removed. And decompression was required.
What advice will you give to this patient for the future?
The future advice would be to not to have a spinal or epidural anesthesia anytime required in her surgery. Yes, she's a primary and she's elderly primary also. She might, and she should be under continuous follow-up of the neurosurgery and neurology department.
Angiogram should be done.
So thank you very much. Give the presenting department a big hand.
Okay. Dr. Mathur's visit is part of our breast survivorship program, which aims to raise awareness about breast cancer and provide survivors with access to the latest reconstruction possibilities. He is consultant plastic surgeon at renowned St. Andrews Center, Broomfield, UK. Dr. Mathur is an expert in the field of breast reconstruction, and his visit is an incredible opportunity for us to learn from his vast knowledge and expertise. He has worked extensively in the UK and has been instrumental in developing new technique and approach to the breast reconstruction. I would like to extend a warm welcome to Dr. Bhagwat Mathur and thank him for his time and dedication to this program. We are honored to have him here with us today and look forward to learning from him. I would like to request Dr. Mathur to say a few words. Thank you.
Namaskar, good morning, Dr. Swankar, esteemed faculties, trainees and students. I am Dr. Mathur, I'm from Jodhpur, and I have had my basic plastic surgery training in SOS Medical College. I would say a long time ago. I was probably from the second batch of MCH from this college. And since then, I had specialty training in Germany and Scotland. And now for the last 22 years, I'm working at the St. Andrews Center for Plastic Surgery, which is in Chelmsford, about 40 miles from the London. And it's probably the biggest plastic surgery unit with 27 consultants. And each one of us are doing different things. Breast reconstruction, we are about 7 consultants. And our service is totally dedicated to breast surgery. Breast surgery means the restoration of the size, shape, and appearance of the breast following breast cancer. We all know that breast cancer, the incidence is about 1 in 9 women get breast cancer in their lifetime, and about 55 to 60% of them get mastectomies and they need reconstruction, which could be done in immediate and delayed settings. The reconstruction could be implant-based, autologous, or a hybrid reconstruction, which is what we offer. And then the other part of breast surgery is kind of, you can say cosmetic. I would not say cosmetic because the cases which we deal, they are basically congenital developmental deformities of the breast, which are tubular breast asymmetries, inverted nipples. And then we come across lots of hypermestia, very large, enlarged breasts, which are normal by all means, but then they are abnormal because they are causing disturbance in your life. In every walk of the life, you get excessive sweating, eczema, and they all need some kind of sort of revision in size and shape. So breast reductions, hypoplastic breasts which need augmentation. So all these surgeries are done by us, And I am involved in, breast reconstruction awareness activities in India. For the last 11 years, we have started what we call as BRASCON, which is a meeting where I come with the faculties with me, and we do operative sessions and presentations, and we take it in different part of country every year. We had it twice in Jaipur as well. Now that I have come to sort of end of my active NHS career, and when I come to India, I always feel that there is no such service which can give comprehensive, breast surgical experience, management of the breast cancer, cancer reconstruction, and the corrective procedures. And I'm really on exploration of an opportunity to come out with and help in development of such service. That is basically my introduction, because they say, what you do is your introduction, not how you look. So thank you very much for giving me this opportunity to be here.